Yes, that's a great question. I think that we have to take into account the results of DESTINY-Breast04, that is a clinical trial in a similar setting of patients. But for sure, we cannot compare directly the two studies for many reasons that you can understand very well. The study design, ICARUS-BREAST01 is a phase 2 mono-arm trial, whereas DESTINY-Breast04 is a larger trial, a randomized phase 3 study. However, if we look at the outcomes, we can see that the objective response rate, the progression-free survival, the duration of response are quite similar. So the data of ICARUS-BREAST01 are really promising, are really challenging for this reason, for the outcomes that we can see there. So for sure, we need to confirm, to validate these results in a larger trial. But what I think is that there is room for other ADC in this population. I mean, we need to have other ADC with different targets. We need to have ADC with a different safety profile. So we can imagine that in the future, we are also able to better select, stratify our patients according to different type of biomarkers. So the fact that today we are exploring a new ADC in this setting, I think this is a very good news, and for sure we need to confirm these results in a larger phase 3 study that has just started, that is HER3-DXd. We don't know yet, but we can start to figure out some situation. I mean, for patients with HER2-0 breast cancer, so patients that do not have HER2 expression at all or very low, trastuzumab deruxtecan is not an option.
Yeah.
And they represent about 20%, we could say, of the HER2 non-overexpressing breast cancer patients. So for these patients, HER3-DXd can be a valid option because they are not eligible to a treatment with trastuzumab deruxtecan. On the other side, what we have seen in ICARUS-BREAST01 is that there is this signal that patients with a higher HER3 expression are the patients that are likely to derive a longer benefit in terms of progression-free survival from HER3-DXd. So what we need to understand is if we can better define this population that can benefit much more of HER3-DXd instead of T-DXd. But again, this is something that we have just seen in this trial. So this is just an hypothesis generating study, and we need to confirm this hypothesis in a larger setting. I think that we are not so close yet. I mean, in our study, we found that SR1 mutation were much higher in patients that were non-responders to the treatment. So we tried to understand why, first of all. Our hypothesis is that these tumors are more luminal tumors, and this is the reason why they respond less to a treatment that is a cytotoxic treatment. And according to this, we found also that p53 mutation were associated to a better response to HER3-DXd. The other hypothesis that we made is that in patients with SR1 mutation, we have a constitutive activation of estrogen receptor signaling that has a potential crosstalk with HER2 and HER3, and this crosstalk can determine a downregulation of HER3. So these are just hypotheses. We need to confirm this hypothesis for sure. But this is a signal that is very interesting. And what we need to understand is if indeed patients with more luminal tumors, so luminal tumors that are still estrogen receptor dependent, are tumors that can benefit less of a treatment with HER3-DXd. So I think that we need to continue to investigate this hypothesis because it can make some sense. I I think that it means a lot because we start to have a number of evidence that are going into this direction. We observed this in the prior DAISY clinical trial that was a study in trastuzumab deruxtecan, and we observed that indeed the HER2 spatial distribution can affect the response to the treatment, and particularly in the cohort of DAISY of patients with HER2 overexpression. And in the ICARUS-BREAST01, we observed that on one side, the spatial distribution of HER3 of the target was associated with the response to the treatment by using again a similar pipeline in terms of IE digital pathology. But also we observed that thanks to the possibility of collecting the tumor biopsy on treatment, that the tumors that presented a higher proportion of cells that were positive for the ADC, for the HER3-DXd, were the tumors that obtained a much higher shrinkage thanks to the treatment. So I think that we need to invest a bit of more time and a bit of more efforts in order to understand what is the intratumoral distribution of the ADC and how much the intratumoral distribution of the ADC can correlate with the response. And we have seen this also with simple antibody, the distribution, the intratumoral distribution of the naked antibody can be associated with a different response to the treatment. And the distribution, in the peripheral distribution of the antibody was seen in different tumor types, and it was quite different as compared to the intratumoral distribution. So we need to understand with this large molecule how much the diffusion in the tumor can affect the response to the therapy. Yes, and there are some trials that are currently ongoing that are combining HER3-DXd with immunotherapy, and I think that this is one of the most interesting direction to go. The combination of ADC in general with immunotherapy, and particularly with the HER3-DXd and immunotherapy. What we saw in ICARUS-BREAST01 was that there is an upregulation of interferon alpha and interferon gamma pathway, particularly in patients that were responders to the treatment. What we didn't see was the activation that we would have expected of the T cell population. We are not able today to explain why. Maybe there is this immunosuppressive tumor microenvironment, but we have to investigate a bit more in depth why we don't see an expansion of particularly of CD8, CD4 in the tumor microenvironment. But the fact that there is this upregulation of the interferon alpha and gamma pathway that is likely related to the DXd, so to the payload, to the activation, distinct pathway activation related to the DNA damage that is determined by DXd, is something that can in some way increase the likelihood of having with ADC a good companion for the immunotherapy. The question is, who are the patients that can benefit the most of this treatment and the patients that can benefit the most of trastuzumab deruxtecan, but also the patients that can benefit of other ADC that I expect will come in this setting. So what I would like to see in the next future is to have biomarkers that are not only the target expression, because we have seen that the target is not a reliable biomarker for understanding, for predicting the response to the ADC. So maybe we need some composite biomarkers that include the different tumor characteristics and patient characteristics, but the direction in which we have to go is that the one of understanding how to better pick up the right ADC for the right patients. And so we need more study that compare that are able to compare different type of ADC and that also take into account comprehensive tumor characterization in order to better identify the potential biomarkers for the future.